Okay, here we go. So one of the things that I want to be incredibly clear about is that the like demographic characteristics of individuals who may be more like overtly affected by trauma, it's not the individual, it's the systems that disadvantage, marginalize, oppress the individual. So I just want to be incredibly clear here that being like identifying as really anything other than a cisgender male, it's not a risk factor. Sexism, cissexism is the issue. So I just really want us to not apply these things to the individual, and that's a real effective way, I think, to really meet somebody with compassion and understand the contextual and macro level factors that affect an individual. So for example, age, it could be like ageism that is the issue. In terms of race, that is the systems of white supremacy that are these systems that are put in place to institutionally marginalize and oppress individuals. So in terms of poverty and low socioeconomic status, you could argue that the system of capitalism and the, this reliance and value of productivity and our identity so closely connected to what we do for jobs. So just really I really want us to conceptualize human beings in larger systems that absolutely affect them. Does anybody have any questions about what I just said? Anything you want me to clarify? Also, what I will say is if anything that I just said right now like sits kind of weird with you, I really encourage you to explore that. Because systems that are put in place to disproportionately advantage and disadvantage individuals are put in place for a reason, and they work exactly the way that they were meant to work. So if you have a reaction to that, I really encourage you to explore that. And then of course, there are things that we need to take into consideration, like historical events. Like if there was some family dysfunction, maybe there was like neglect, abuse, there's been previous trauma exposure. These are all things that increase the risk for somebody to have a trauma experience and or just difficulty in coping with that and potentially having some more long-term PTSD symptoms. And again, so just really wanting to highlight here, gender and race, always are at play in the way that we navigate the world, that we move about the world. So it's really about these systems of racial and sexual inequality. And just throwing out there that, individuals who are, who identify as women have a lifetime prevalence of PTSD at 10%, double that of individuals who identify as men. So just some, more kind of structural demographic things, systemic demographic things to take into considerations. So these are, again, we're still in the assessment piece of this class and understanding the effects of a traumatic experience or trauma exposure. So these are all of the types of questions. So I really want to get all of you comfortable when you are talking with an individual across from you or a system across from you, using these terms. So same as, when it's very different to ask somebody, do you have thoughts of hurting yourself, as opposed to, do you have thoughts of killing yourself? Those are two incredibly different things, and you're going to get different answers based on how you ask that. Now, I'm not telling you to be like crass or anything, but at the same time, these are experiences that are real. So if you're going to say, have you watched somebody maybe be uncomfortable? As opposed to have you seen an intentional act of violence committed against another individual? Just being comfortable having those words roll off your tongue. Have you experienced any sort of sexual coercion? Have you been asked to or forced to engage in any sort of sexual act? And I will list these out that was against your consent or that you did not consent to. So just wanting to get you comfortable with language in your assessment. So one of the big themes that you probably gathered from this week's reading is some of the complex PTSD. So essentially having this compounded experience of trauma where you have a family of origin experience and then potentially something also that's happened in adulthood, and that trauma experience in your family of origin as a child absolutely, through the research, affects the way that somebody copes with a later trauma. So like it says here, research suggests that childhood traumas are even more related to lasting psychosocial difficulties. So as we've read about this week, difficulty forming relationships, difficulty trusting, and there's good reason for that. In terms of being in this state of survival, this state of confusion, and you're brought into a world that you don't know anything different than to potentially not be able to depend on individuals, to expect to be hurt in some way. And so given that this is an incredibly formative time in a human's life, and I'll talk about this in a later slide, that trauma forms and informs a schema, a thought, a paradigm, of a belief system, a way of thinking that informs how you move about the world and how you move about your life in relating to others. So incredibly formative in that way. So some things that you could be looking for or assessing for is any sort of disrupted parent-child attachment. So going back into family of origin, understanding the dynamics between the individual in front of you and their caregivers, or, kind of like important adults, grown-ups. How are they, and then these are things that you're going to be looking for in the interview, where they're not explicitly sharing it with you, but you're watching body language, you're watching arousal. So what is their affect regulation like when they're in front of you? So these are all those nonverbals that you're going to be looking for, asking questions about identity, and seeing if there's some, maybe discrepancies in formation and things like that. And then forming, again, that interpersonal struggle with forming positive and lasting relationships with others. So these are all things that you're going to be looking for. And, if they are existing in that individual, there is the potential to further explore abuse and neglect and trauma in their family of origin. Also, just to remind you all, if you have questions, please don't hesitate to speak up. So what is protective? That, we look a lot at what is this individual struggling with, but we also have to look at what is in this individual's life that has been helpful, or if it's not, like, what do we know to be helpful? And if it's not there, how do we grow? So social support is one of the most powerful determinants of essentially like mitigating the lasting negative effects of trauma. So this can be from family members, friends. So these are, when you are assessing a support system, you're going to ask, who in your life do you feel safe with? Is there anybody existing in your life that you feel like you could go to and talk to about your troubles. Sometimes I will say this because it becomes heavy for us as a mental health professional. You know, sometimes that person's going to look you in the eye and very honestly tell you, you, therapist, are the only person that I have. And I want you to not receive that and feel pity for the individual. You're receiving that as information to help them, kind of find their people. So it can feel very heavy. It can feel like a lot of pressure. I'm going to encourage you to, one, if that happens, it's natural, it's normal. That's a lot to be like, oh my gosh, I am the person's person. That's your job. So you're doing something really good in that sense. You also have the opportunity to help that person build a system. So this support looks like people accepting and not blaming the individual when they share their trauma experience with them, having caring and nurturing from people that they love and who love them, and then also having availability of helpers and support or aid agencies. So again, we talked about this either last week or 2 weeks ago, those like basic human needs for safety. So safety is always the first thing that you're going to be assessing for. Do they have adequate housing? Do they have food? Do they, are they able to, have their needs met on a day-to-day basis? Or at the very least, do they know where to access resources? At the same time, social acceptability of the trauma absolutely affects the response. So the example that was given in the book was, if there's, a survivor of a natural disaster, that's looked a lot at societally a lot differently than, for example, like a sex worker who was sexually assaulted while they were working. It's, the question, the attitude toward it is so different. One is, oh my gosh, that was completely out of your control. Wow. Like, what are the chances? And the other one's kind of like, well, like, what did you expect? And they're both traumas that are both valid and both worthy of care and compassion. But as a society, we don't provide that. We definitely are valued in terms of how we respond to traumatic events. So the trauma can alter the meaning that, so I wanted to like pull this out and highlight it, because trauma, it can be so like interweaved into our very, like the fabric of who we are and how we see the world. So it can alter the very meaning we give to our lives and can produce feelings and experiences that are not easily categorized into diagnostic manuals. So we've talked about this in terms of, and then you read it this week of, just some of the miscues that we have in the Diagnostic and Statistical Manual, and how it's still evolving. It will never be perfect. But at the same time, so looking and seeing like kind of how pervasive this trauma narrative is for this individual, and get kind of almost getting a timeline of, tell me, how you navigated the world and how you moved about the world prior to this event. So again, it could be acute, it could be chronic. If there was a before of the event, kind of trying to understand that individual and them as a person at that point. Because again, what all of this is, as a therapist, what we will provide that individual is this integration, right, of the like kind of pre-trauma individual, that during trauma or in that traumatic event, and then post individual. These are all essentially like kind of chapters of the same book. But we may forget the pre and during, and then lean into that post. And it's like this balance of acceptance, integration, as well as grief and mourning. So these are all part of the process. Does anyone have any questions about what I mean by integration of like, so I had potentially like a different identity, a different meaning of life at this point, and now this trauma has occurred and that no longer applies. So there's like kind of this potential mourning of that pre-trauma vision, or potentially that meaning is still applicable, and we're trying to understand how we can have these seemingly, so post, pre, like simultaneously potentially contradicting or different experiences and beliefs, and have them be, like I said, simultaneously existing. So that may sound kind of abstract. Does anybody have any questions about that? What I mean by anything? I can't see any of you. I'm just looking at a green light over here. Okay. So when we talk about, when we're reading about the effects of trauma, we read about depression related, anxiety, and stress. So these are kind of the three major categories that trauma like occupies. So as it says here, there's significant overlap amongst post-traumatic stress, grief, and depression. And then we'll also pull some anxiety into that. So just getting you familiar with some of these, because this class isn't a diagnosis class. I will leave all of that diagnosis and, thumbing through the DSM for your diagnostic class, but just getting you familiar with some of the terminology here. So basically with this, the purpose of pointing this out is depression should always be considered in the work that you do with individuals who have been traumatized. So there's complicated or traumatic grief. So grief is a very normal response to any loss, and often it does resolve over time. So we know kind of the stages of grief. Again, imperfect. It's not linear. It can be very recursive. It's likely, not complete. We have the tasks of mourning as well. So it's particularly for those who have, maybe not experienced any sort of loss prior to when they see you. Grief is all encompassing. It's incredibly overwhelming, and it can feel kind of like post-traumatic in some way, but they may not meet criteria for good reason, because things like flashbacks, things like, what can look like depression in terms of, not wanting to get out of bed, lacking joy, feeling like that. Those can be kind of convoluted with grief. So just the reason I say all of that, this is to really normalize the process of grief. It's not to dismiss it and say, oh, you're just grieving, but to really give some psychoeducation on grief, and to, really validate that person's experience while really normalizing it as well, that grief will be part of the process if there has been a loss, even if the loss is like, kind of seen as by others as kind of beneficial. Like, so let's say, for example, this person was in captivity and their captor died. You might think, well, good, that's something that's, this weight and this pressure and this like negative energy that this person no longer has to deal with. Maybe that's how the survivor feels, but maybe there's also grief. It's not an either or. So it can be I'm relieved at the same time sad, or I'm just sad, or I'm just relieved. So then there's major depression. So when depression is a significant component of an individual's post-traumatic picture, this is where some medication might be helpful. So again, you have to really investigate your own thoughts about psychopharmacology and about medication for mental health issues. I would encourage you to see the validity in that. And at the same time, recognize that what we know is has been the most beneficial is complementing any sort of medication also with talk therapy, with psychotherapy. As we know, we usually, we're a society where it's pop a pill, take something and don't process it, just reduce the symptoms. So it's an interesting balance that we have between the mental health field and the medical field, because the medical field works from kind of the disease model, right? So it's just symptom reduction. Not everybody in the field, but largely the field is informed by what's considered the disease model. We work from the wellness model. So we see like inherent strengths and then we try to build on those things. I would argue it's like more holistic, but at the same time, the two things can be very beneficial for the individual, both medication and talk therapy. Then there's psychotic depression. So regardless of the reasons for the associations between the stress, depression, and psychosis, you should be alert at the possibility that significant trauma exposure in those who complain of both psychotic and depressive symptoms. So if you have somebody presenting to you that has psychotic symptoms or depression symptoms, it is like an indicator to you to assess for trauma, any sort of trauma experience. So what likely one of the takeaways that you got from the readings is assess for trauma, like kind of regardless of what's coming to you. Of course, depending upon your, theoretical lens, but there's a good chance that trauma has something to do with why someone's presenting to you. So then again, anxiety can absolutely be what you see in an individual, what they're like presenting concern could be. And again, assess for trauma. A trauma could be informing this. So this anxiety can reflect the impact of threatening events, and this should be addressed when you are assessing and then potentially integrated into the approach that you use with this individual. PTSD is also often associated with panic attacks. So if you are seeing panic attacks, this would be an indication for you to assess for triggers and understanding what is going on with the individual. So you should inquire about any episodes of panic when you are evaluating this individual and see if there was some sort of trauma exposure, and that you should consider the possibility that panic attacks in any trauma survivor may represent a form of post-traumatic stress. Then there's phobic anxiety. So this is avoidant symptoms in both post-traumatic stress disorder as well as acute stress disorder. They can look phobic. So when you are, so let's say you have an individual presenting to you where they are, they don't leave their house, and you might think immediately, oh my gosh, this person's agoraphobic. But you have to also take into consideration that's the symptomology, or like the coping for a traumatic event can absolutely be avoidance. So understanding if they're not doing something or not going to a place, that it very well could be, something that they experienced or reminiscent representative of a traumatic experience that they have. So if they involve efforts to avoid people, places, or situations that are reminiscent of the trauma, it's usually because of fear associated with that stimuli. So again, not just kind of slapping this phobia, thumb to the DSM and give them some sort of phobia diagnosis, that you really want to make sure that you're fully assessing for any sort of trigger, some trauma experience. Okay, so one thing I just wanted to note for those of you who may be working with insurance one day, is so sometimes insurance companies may not be, they're not super cooperative all the time, particularly as couple and family therapists. We see issues as relational, and the DSM doesn't really have relational codes. We used to, and you used to be able to, depending upon the insurance, you could bill for what's called a V code, but that was in the DSM-4. V codes do not exist in the DSM-5. So many times how we diagnose, or like when we're working with insurance, of course, ethically, but I would argue that, any time somebody's coming to us, they're probably adjusting to something, whether it's, you know, interpersonal, intrapersonal, that they're coming to us because like their coping skills, the distress from the event or situation is greater than their existing coping skills or coping resources. So anyway, but what I wanted to say was sometimes adjustment disorder, you're given like a time limit on it, even though there's both a like persistent and a chronic type. So adjustment sometimes, or coverage, insurance coverage for an adjustment disorder diagnosis, you only get 6 months for that. But I just wanted to like note to all of you that you could look into also using other specified trauma and stressor related disorder or unspecified trauma and stressor related disorder. So, you know, look around the DSM to help you out in terms of getting not only reimbursement, but also, you know, resources for your clients. All right, so dissociation is also something that absolutely can be related to a trauma history. Some dissociative responses appear to be associated with childhood neglect experiences or early insecure parent-child attachment. And sometimes this is irrespective of later traumatic experience. So just again, so dissociation can look very different for individuals. Dissociation can be, or, you know, how we talk about zoning out. Sometimes it's just like, I don't know, our brain's wandering. Sometimes it's dissociation. So again, if you're seeing a pattern of that, where, you know, an individual is remarking that they have like out of body experiences or they feel like they're not in their body. These are usually descriptors of some level of dissociation. So it indicates to you to look a little bit into their family of origin. So somatic symptoms and related disorders. So again, these are all just like presenting issues that somebody would come to you with. And one of the things that happens, and I think I'm going to talk about this in a later slide, is that, so if I'm coming to you and I say I have anxiety, likely, well, I would say the majority of clinicians who potentially are not trauma informed would just work to decrease anxiety symptoms, right? And they're not necessarily looking for an origin, or they're not looking at it from a trauma informed lens. And sometimes we don't even make the connection with that of, oh my goodness, like the anxiety I'm experiencing today has some origins in my family of origin. So I just really encourage you to allow space to assess that. At the same time, so it's like this balance of like assuming that we're affected by our family of origins, right? Like, so I think that's a pretty safe assumption. We talk about, you know, not assuming in our field, but to assume that we are affected by the experiences we had as a child, I think is pretty fair. At the same time, if no trauma experience is indicated, you know, not pushing that and saying like, it must be this thing, like this is what we're learning about, that it's trauma informed. Because it may be that there was no trauma history. It also may be that that person doesn't want to disclose it to you yet, or doesn't feel comfortable doing that. So, you know, being willing to back away from that, continue to build that rapport. And if it comes out, it comes out. If it doesn't, you're just going to continue to treat that individual with, you know, compassion and patience. So somatization has been linked with a history of childhood maltreatment, particularly sexual abuse. So these are, you know, bodily, what's the word I'm looking for? Issues, complaints, that's what I'm looking for. So, you know, upset stomach, that may not have, you know, origin, like, you know, if you do a scan, you may not really see something for it, like a, you know, organic reason for it. So the reason, or like the connection between the two of somatic symptoms and trauma, it's unclear. So we don't really have like kind of this like formula or very clear understanding of why the two are linked. We just know that like both anecdotally and empirically that they have been linked. So possibilities include the effects of sustained automatic arousal in organ systems, especially responsive to sympathetic activation. So this is, this over arousal, this potentially hyper arousal or hypo arousal, to the point where you're no longer really in touch with your body, or your body's really not reacting to external stimuli in a consistent or predictable manner. Trauma survivors with significant medical concerns should be, so when they come to us, they have these medical concerns, we should refer for a full workup. So this is, really informed by that biopsychosocial model that we work with. We work in the psycho and social, right? We're informed of the bio because we have to understand how the bio affects both the psycho and the social. We are not medical doctors. We're not in the medical field. So if there is something like biologically, physiologically going on with the individual, no amount of talk therapy is going to help that. So if they come to you with a medical concern, an ailment, a complaint, please refer them to a medical doctor who will be able to do a workup in a way that you won't be able to, so that if there is some organic explanation for that, that you don't focus there. Because again, if there isn't an organic reason for that, then we move into that psycho piece, right? Of understanding how the brain is so powerful in the way that it affects the rest of the body. But if they're, if they have cancer, we can talk about the effects of that, but we can't treat the cancer. That goes without saying. So then substance use, as we know with trauma, substance use is a pretty common, it can be a common comorbidity with trauma, or like PTSD, ASD. So 3 major reasons why trauma, PTSD, and substance use may overlap. So the first is that the survivor will seek out psychoactive substances as a way to self-medicate. I am in my own head all the time. I am experiencing rumination. They may not know what that is. I'm having these, unwanted flashbacks, these memories, and I just need to not. Substances are a very predictable, consistent way to, even for a moment, give yourself a break from that. Those who use substances, unfortunately, are more victimized and prone to trauma exposure. So, just thinking about like where this individual may need to go in order to get their substances, the places that they may be under the influence, situations that this person may be in. So there's this cyclical pattern with substance use and victimization, or trauma, where it's like the trauma happens, like, because sometimes it's kind of like chicken and the egg a little bit too. Like, do you start with the substance use or do you start with the trauma? But let's say that an individual experiences trauma, they're using substances to help themselves self-medicate. They are under the influence, experience more trauma, so it's like just this really vicious cycle that can happen. And then major substance use, though in the moment, very understandable, potentially, I won't necessarily say adaptive, I will say applicable. But the more that the individual uses, the less they're processing, and the more kind of like alive the trauma is staying, because they're not really addressing the trauma, therefore addressing the substance use. So the more avoidance of the processing or of the trauma essentially begets more trauma, and not necessarily in it happening again, but just keeping it very alive and present. I'm going to go through just a couple more slides, guys. I know that we're at an hour, but I want to kind of try to chop this up into parts that make sense. So like I was saying, I won't need to necessarily, go into this cycle of the trauma exposure, likelihood, early trauma exposure increases the likelihood of traumas later in life. Not necessarily, again, it's not causal. There's a correlation. This can be things like the schema, things like coping, things like, interpersonal relationships. It can also be, brain activity. What we'll learn when we get into the body keeps the score is just how much trauma affects our physiology. And then the accumulation of these traumas can lead to this post-traumatic stress, and then that interferes with the development of any sort of affect regulation skills. So again, trauma affects the way our body responds to stress and, difficulty. So we don't learn to trust our ability to regulate, or we don't even know how to regulate. So then if you have this difficulty with affect regulation, then when you experience distress, you can't necessarily organically cope with it. So I'm going to bring in some reinforcements in the form of a substance. And then drug and alcohol use can lead to decreased environmental awareness and involvement in risky behaviors. Or potentially it's also the trauma of I don't deserve respect. I'm not in charge of my own body, these types of things. So it's not only you're under the influence of a substance, therefore, there's inhibitions are lowered, things like that. There's also an existing belief system of yours, of the individuals that might, not feel like they deserve any sort of humane treatment. So these increase the likelihood of additional trauma, and then this can lead to more substance use. So that cycle. Okay, I'll go ahead and stop the share here, give you all 10 minutes to break. I'll go over a couple more slides, and I have an activity for us. So I will see you back here at 11:13. All right, I'll pop back into the PowerPoint here. Okay, so this is a little bit of a primer for our activity that we're going to be doing. So understanding complex post-traumatic stress disorder, which is not yet a diagnosis in the DSM. It has also been known as, or what is kind of used for it, is the disorder of extreme stress, not otherwise specified. So that's what the DESNOS means. So thinking of complex trauma, the relational and identity disturbance that can come from this type of trauma can include a tendency to be involved in chaotic and frequently maladaptive relationships, having difficulty negotiating interpersonal boundaries, and reduced awareness of one's entitlements and needs in the presence of compelling others. So I think we talked about this last week of that, fawn response. We talk about fight, flight, or freeze. There is a fourth response called fawning, where you basically just accommodate people around you. You kind of assume their characteristics and really kind of become as small as possible and blending in kind of like a chameleon. So that is another response to trauma. So when you see relationships that, this pattern of relationship history that has characteristics like this, and again, part of the identity disturbance in this is, not really knowing where I end and someone else begins. So you can see what would be considered kind of like codependent tendencies potentially, or I guess on the other end of the spectrum, very avoidant kind of protective characteristics that the person displays. So again, when you see something like this, when you see a relational history or relational pattern in this way, this can be potentially attributed to a history of inadequate or disrupted parent-child attachment. And which could include things like abuse or neglect. So I would like to talk about BPD for a second. So borderline personality disorder. Actually, you know what I'm going to do? I'm going to stop my share here because I want to have a little chat with all of you. So how many of you have ever heard the term like borderline used in a pejorative way? I have. Has anybody else? So one of the things that I really want to, I don't know, because I want to understand whenever you're in systems, you have to understand the bureaucracy and the politics and stuff like that. But one of the things that I think mental health providers do, one of the areas where I think we really do a disservice is when we see an individual who has some of these more like hot and cold relational tendencies where it's, borderline is kind of the classic, I hate you, don't leave me, right? I want to keep you at an arm's length distance because there's a comfort in you being kind of close, but if you get too close, I'm too vulnerable. I don't know what to do with this. I don't trust you. I don't trust people. So this is a really common trauma response. So one of the things that I want to encourage all of you to do when you see like that relational dynamic, that should perk your ears for assessing for some trauma, because we're very quick to just slap a borderline diagnosis on someone and then kind of write them off. Because again, it's, oh, they're borderline. Oh, I have another borderline. They're so draining. They're so exhausting. Borderlines are the only one that I don't give my number to. If you do like some private practice, or it's just some providers give their cell phone to their clients. And, so anyway, it's just, I think it is, in my opinion, a very uncompassionate, not compassionate way to look at humans, and not honor their history. So I just wanted to check with that, because I in several of the readings, it said basically like calling somebody borderline, because it's not even like you take the humanity out of it, right? It's like they're a borderline. It's like they're an individual with a diagnosis of borderline personality disorder. But anyway, just how we use it as this very like sophisticated dig at somebody, and it's just really unfortunate. So just wanted to have us look at each other when I was talking about that. So let me get back to this slide.
Sorry, Dr.
Yeah,
Lappin,
please.
I had a comment about that.
Absolutely.
Because I had a client who was like referred to me from a therapist who is leaving my practicum site. And
Sure.
that was one of the things she told. We had like a conversation about her just updating me about the client.
Mhm.
And one of the things she said was that he was, I don't know how she worded it, but pretty much that like he was most likely had BPD.
Mhm.
And like I recognized within like a couple sessions just how much, just hearing that, aside from all the other information she gave me, was like I just had like this distance that I felt with the client, and that I felt like worried about making him upset a lot. Like I just was like, oh, he's gonna get angry at me. And then I ended up talking about it in my supervision and kind of like doing some self-therapist about it, that I felt like it was just like my own stigma
Absolutely.
related to that. And then the more I like just opened myself up more to the relationship with the client, he's like talked about all of his childhood trauma that like clearly is like a big cause for him having certain symptoms. But it was almost like I wished I wouldn't have even talked to the therapist before and just like
Yeah.
gotten to know him as a person, and understood him that way. And like the relationship has gotten better, but it was, yeah, it just like that, just those words and like the power that they hold really can like impact client relationships.
Absolutely. Thank you so much for sharing that page. And you're right. I think we do individuals a disservice from the educational level. Like, I don't know if you have taken, psychopathology or diagnosis where it's like individuals with borderline personality disorder are difficult to work with. And that's like almost like an opening line of like, it's not on you interpersonally. That's why we have special training. We have dialectical behavioral therapy to work with individuals who have this diagnosis. And I would argue every single human on the planet would benefit from DBT. Because it's just helping you in relationships and with affect regulation and stuff like that. But yeah, thank you so much for that page. And it's, one of the things I think you bring up a really beautiful point of, you will be transferred clients at, some point, whether you're in your internship in a practice, that just happens where somebody's leaving, the schedule doesn't work or something like that. Then you get this kind of like snapshot of a client that can absolutely influence the way that you conceptualize that human. So I will encourage all of you when that happens to take all of that with a grain of salt, because just like exactly what you alluded to, Paige, self of the therapist, that is a huge factor in how we relate to humans and how we conceptualize them. So you're working from somebody else's perspective. And then when you take that to kind of like concretely, it can be completely irrelevant or not applicable in the way that you work with that person.
And I think there's another layer to that too, of like how the client or how human beings like internalize those things as well.
Of course.
Like being diagnosed with something like ADHD can easily become a self-fulfilling prophecy, or not even a diagnosis, but just being told my child is shy, and then they grow up thinking that they're shy and acting shy because they've internalized like that quality of themselves without really exploring who they authentically are.
Absolutely. Even more reason to understand some family of origin stuff. Yes, and that's a double-edged sword of diagnosis, right? That it can open up opportunities for resources. It can also be internalized. Not that that's necessarily a problematic or maladaptive thing, but just like you said, it can become the reason for certain behaviors so we take away kind of the agency, our own agency, and saying, well, I am ADHD, I have ADHD, therefore I have no choice over this. And I'm not saying that we can, behavior or choose our way out of something that's going on with us physiologically. But I definitely agree with you in terms of just having other explanations or other choices with what we do. Okay. Thank you for that, guys. All right, I think we've talked enough about here. So cultural considerations. One of the things that I will absolutely say, so again, the DSM is culturally informed. So just like it says here, Anglo cultures. So these are, white European cultures. So just the diagnoses that we have are culturally bound. So understanding that the meaning behind certain trauma responses, they are culturally bound and they can have something different. So the DSM does recognize this, or I guess I should say the authors of the DSM does recognize some of the cultural bound nature of diagnosis and of trauma. So here, it allows for coding of culture-bound stress disorders like ataque de nervios, as something that you could code as other specified trauma and stressor-related disorder. So here, the last piece that I want to highlight is the existing literature suggests that cultural variables can impact trauma responses, and therefore we should be vigilant to the possibility of trauma syndromes above and beyond like what classic diagnoses for acute stress disorder and post-traumatic stress disorder, how they may present. So just knowing that, you know, maybe somebody doesn't meet all of the criteria, but you have that other specified trauma and stressor related disorder, again, to give potentially, because again, diagnoses they're not bad. It's can be very liberating to say, oh my gosh, what I'm struggling with has a name. Like, I'm not the only person that struggles with this. Again, like Miles alluded to, there's the other side of that potentially, or another side of that, I should say, of, you know, this internalizing and feeling like you're kind of relegated to this, but just being aware of the cultural considerations. Okay, so now what I want to do is give you a chance to apply some of this compassion, and, you know, really learning how to look at individuals through like a trauma-informed lens. So, you know, we look at we hear these terms, you know, so these is particularly with, well, these can absolutely be trauma informed, right? But we put these like very negative labels on individuals, like manipulative, lazy, resistant, unmotivated, disrespectful, attention seeking. I mean, I'm just thinking of like resistant, unmotivated. People call clients that all the time. Lazy, that's their attention seeking. Like, how many times has that been slapped on a kid? So your trauma glasses are off, or people's trauma glasses are off. What I would like for us to do in rooms is to provide just like it says here, a alternative explanation for these adjectives that it says a student here, because I pulled it from like trauma informed teaching, but this is absolutely applicable to clients. So an alternative explanation as to what you're seeing. So for example, I'll stop the share here. So all of you have access to this, right? So I just want to make sure when we go into the breakout rooms, we have these listed. But so for example, I'll help you guys out. I'll lead you on this. So we'll go with lazy. With trauma glasses on, you could look at this individual as overwhelmed, potentially lacking the skills to make decisions about what to do first or how to organize. So again, it's like, instead of just slapping this like kind of identifying adjective on this person, that you're saying, what is a different way to look at this individual? So they're exhibiting these behaviors that one may call manipulative. I want you to give a different description of that individual. Does that make sense? Okay, so I'll put you probably in really similar breakout rooms. I'll give you like 15 minutes to, we'll go 10 minutes to do this. And then we have like a reflection activity after this as well. All right, same rooms.
establishment of this brand.
First, I wanted to ask all of you, like what you came up with in terms of, relabeling some of those, more negative, those labels that have more of a negative connotation through a trauma lens. So I'll go to I won't share the PowerPoint, but I'll just refer to it. What did you come up with for manipulative?
Kind of said, perhaps they haven't been offered what they need.
Mhm.
And so they came up with a clever way of like convincing someone else of their needs or wants.
Great. Yeah, the example has getting needs met in ways that have worked in the past, doing whatever is necessary to survive. I think that piece is really important. So again, thinking about individuals who have grown up a certain way and having the like basic need of survival at the forefront. Doing anything beyond that really is a privilege. So just framing it in a different way. What about resistant? I'm interested to hear this because you'll hear resistant clients all the time.
We said fearful. We thought fear kind of went with a lot of them. It was most of them, we were able to bring up some kind of theme of fear. So we thought if someone's resisting, it's because they're afraid to do whatever it is they're resisting.
Great.
Something my group mentioned was maybe they're just not ready for the intervention. So maybe it's like too much of a big step, or they're not able to, maybe they're lacking resources. So it could be other things besides themselves necessarily.
Yeah. And Orna, I really appreciate that because, you're doing what we always try to teach in terms of system thinkers is always having alternative explanations. So it's, whatever the common explanation is for something, part of your job is to make sure that you've exhausted all options of what it could possibly be. So you're being very diverse and varied in the way that you're assessing and conceptualizing something.
Thank you.
Yeah. So what I have, again, so this is just like an example, is mistrustful of others due to a history of being hurt, scared to make progress and then lose everything. So remember, with change comes loss. I don't think that we always honor that piece of change where it's like, oh, look what you're gaining. You also have to look at what somebody's losing. It may be some kind of perceived or real, actual, which is, kind of hard to decipher sometimes, like this safety of what their current behavior may be providing them. So if I lose this, what happens to my control? What happens to my safety? What happens to my identity? Who am I without my trauma? So just always thinking about that other piece of change. I think we always think I'm providing them something beneficial. This is only going to be good for you. That doesn't mean that it's not going to be good. It just means that there may be loss in that, and there may be some adjustment that can be distressful in that process. What about unmotivated?
Our group said like exhausted or overwhelmed.
Right. Absolutely.
Also, feeling inadequate
you know, like not feeling like you're able to achieve whatever it is that is being asked for you to accomplish.
I love that. Part of the example is in quotes frozen. And I think inadequate absolutely fits right with that. You know, when we are not moving, what might that be? It could be a feeling of inadequacy. So I'm not going to do anything because I don't think I can do it anyway. Or some derivative of that. Yeah, depressed, fearful, overwhelmed, frozen is in the example. What about disrespectful? A different way to look at disrespectful. This is a really common label that parents will give kids. And just like what Paige was talking about earlier, when someone has a label, it absolutely affects the way we look at them. So if you have a family that comes to you and the parents are our kid is just so disrespectful. That's an inherent trait. When you're labeled in that way, it's different than saying being disrespectful. They are disrespectful. What would be a different way, a more trauma-informed way of looking at that behavior?
I mean, we discussed being confrontational.
Okay.
Also, a little bit of family systems and being reactive.
What is the person reactive to? What might be going on internally with that individual? Or maybe in the environment. Why might someone be reactive? What might they be feeling?
Oh, well, I mean, unfairness.
Okay. So
Sure.
something feels unjust.
Yeah, I mean, not to get off the family system part, but like I was mentioning to my group, I tend to have clients that have issues with being confrontational, like effective confrontation. And so
Can you say a little bit more about that?
sure, when they're so sometimes they don't want to stir the pot or create drama, so they're sort of placate, people crossing their boundaries and stuff like that,
Sure.
and they don't know how to confront. But then there's times when it's maladaptive and they become reactive, and then it becomes something that's totally not like them.
Yeah.
Which is, hey, like, whoa, where'd that come from? And it's like, well, I've been bottling it up and now it came off as disrespectful. So it's, disrespect is still confrontation. It's just not as effective type of confrontation.
I really appreciate that perspective on it too, because what you're taking into consideration is history, right? So let's say there's an individual who has a history of having their boundaries crossed, right? They may placate, again, their response to trauma may be fawn. And then they come to a place where they say, I'm not going to do this anymore. I'm not going to stand for this. I'm going to stand up for myself. So I always think of this kind of stuff almost as a boomerang effect, where if you start here, and then you may go to the other side of the reactions, right? And I always say that with because it's a spectrum, a continuum. It's not like one or the other, where you go, you know what? I'm going to puff my chest all the time. I'm going to make sure no one messes with me because I'm finding my identity, or I'm finding something of the possibility of this being almost a compensation for some history so just really taking the whole person into consideration. So I don't know if that's a little bit what you were alluding to, Daniel. I hope I did it some justice, but that's, I think, a really important perspective of the history that may be informing what you're currently seeing. So here, the example has feeling threatened, unsafe, out of control. So again, just being, that's so much more compassionate than this person's disrespectful. I think I've reframed this in class before, but we'll see what you guys came up with. What about attention seeking?
I said like seeking connection or seeking support.
I love it. Yeah, I will always challenge all of you whenever you hear the label attention seeking to reframe it to connection seeking. Yeah, so feeling alone, feeling unheard, unseen. So I'm gonna, and then as we know, many people get reinforced for behaviors where they get attention. So they say, all I really want is for myself to be seen. What I found is when I do like bad things or things people don't approve of, I get the attention or I get the vision, I feel seen. So I'm just gonna go about it that way. So you have to also understand like the potential inadvertent reinforcement of those kinds of behaviors too. All right, so I'll leave the discussion piece in your groups, and I will go ahead and share my screen and share with you a video.
Dr. Lappin, just a
Yeah.
quick question. Will
Sure.
the like alternative responses be posted anywhere?
Yeah, of course. I'll go ahead and put them in Canvas.
Okay.
So any like anything that I tell you I'll post in Canvas will always be in the files.
Okay, thank you.
Thank you for that, Paige. All right. So let's watch a TED Talk on childhood trauma and its effects across on health across lifetime. All right. Let me know if you guys, can you hear that?
In the mid-90s,
Yes.
Okay.
the
great.
CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of
Oh
the
man.
leading
Okay.
causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the life.
Dr. Lappin, it's
Oh yeah, when I
lagging
mute myself, I
in
mute
life
everything, don't I?
expectancy.
Thanks.
And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities, access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination, and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real and this is all of us. I believe that we are the movement. Thank you.
Any thoughts, reactions to that video?
I think it all sounds really great. And I promise I'm not a conspiracy theorist, but I think in our capitalist society, the medical model works because we're capitalist. You know, she gave the example of a well causing, you know, disease, and we can write prescription after prescription, or we can go fix the well. Fixing the well costs money and doesn't really make us money. Writing all of those prescriptions will continue making money the same way that, you know, everyone says, you know, we want everyone to be healthier and live longer, but at the same time, we're making money off of unhealthy people. I say we, not like we as physicians or clinicians, but as a society. So that's what I was thinking of, was just this capitalist, you know, even the DSM is written by people who are making money off of writing prescriptions. So, yeah.
Yeah, I resonate with that because I do research with psychedelics, and it's a completely different, it's a paradigm shift from the way that we treat presenting issues. Because I'm just thinking of, depression, for example, is, you know, psychedelics have been shown to be helpful with treatment resistant depression. But depression medicine is something you take every single day, whereas psychedelics are something that you take potentially only once. Where's the money in that? So I understand. I've been in a field for a while that definitely has some skepticism in regard to capitalism and how we conceptualize and treat presenting issues. Anyone else?
Dr. Lappin, you know, I'm
Yeah.
into the psychedelics too. Um, and I think a lot of the studies are also coming out right now, the clinical trials like on MDMA, what they're realizing is that it's not just the medication though, it's not just the substance, it's also the psychotherapy. So it's got to be the psychotherapy and conjunction with the medicine. And then you see even more reduction of symptoms and even people who basically don't fall under the diagnostic anymore. But in regards to what Miles was saying, yeah, I agree with what you were saying. Yeah, we're capitalist and that's the system we have right now and that's how we're operating. It's the healthcare management is it's not well managed, right? But I think that what capitalists probably enjoy more than making money is making stuff that's possibly cost effective. And if you can convince people and put that kind of have that paradigm shift that it is cost effective, that maybe opiates are not as effective, right, as let's say the psychedelics we were just talking about. If you can demonstrate that, then you see the shift. And so if we can demonstrate that we can tackle all these health issues by, how she mentioned, metaphorically attacking the well, and that's the cost-effective thing, that's what's beneficial, and that's what alleviate a lot of the I guess misspending and just you know, all of the mismanagement that we're kind of taking on. Then I think that there's a case for it. And I've been in another cohort where, you know, I also touted the psychedelic medicine, and it was kind of and I give my colleagues here, because this is a cohort you guys have been together, so I appreciate being in this cohort and getting to know you guys, but also just remember that, you know, it can become very easy to just go hard on the capitalism and not try to actually try to transform the capitalism.
Yeah, I hear that. Absolutely. Thank you for that, Daniel. Any other thoughts on like applicability to what we've been learning to the mental health field? Punctuating some of the things we've been reading and hearing it from a physician perspective. Okay, so I think what I'm going to do, because we've gotten through 21 of the 67 slides and they're not, it's a lot of highlighting what we've read. So I'll work on some of the like condensing of that information. So I think what I'm going to do is stop us today. We'll continue. So please be prepared with the readings for next week, and I'll incorporate some of the larger messages that I want to take, mostly about like really, I really like Dr. Herman's writing. And I really appreciate like the very unapologetic, like political stances and that are taken, meaning how our field is not pure. Our field is absolutely affected by politics and movements, and we are so interconnected societally. So I don't know if you guys have learned about like the feminist perspective, but one of the basically kind of like tagline, for lack of a better term, with feminism is that the personal is the political. So what we do is inherently political because of the society that we live in and the system that we are a part of. So just really wanting to highlight some of the like biases that are inherent in our field, while also navigating that on more of a micro level, because the work that we do is micro because we are each individual humans that, you know, anyway, I could definitely get on a soapbox about that. But one of the things that I definitely want to highlight from our reading that we'll talk a little bit more about and have some discussion about next week is just how affected we are by what is going on in the larger political and social landscapes. Okay, well, thank you so much, everybody, for being so engaged and participating. Please do all of the readings, come prepared next week. We'll do a little bit of carryover from this week, and have a wonderful rest of your week. Bye, y'all.
Dr. Lappin.
All right, thank
Bye, Dr.
you.
Lappin.
Dr. Lappin,
Yeah,
I had a quick question.
Sure.
So for the paper that's due tonight, I
yes,
already turned it in, but I just wanted to make sure, because I know that in the beginning of class you had talked about, you know, like there's really like no, there's no like right or wrong way to
sure,
do
sure.
it. But obviously I know, I think it was Jada, she was the one who said, you know, like she wrote it on the perspective of like therapists did this, this, and this.
Correct.
And so I wrote it on, I guess, the perspective of I had already seen this client, and this is
Okay.
like a client that I've been seeing, but the now the crisis that had happened, you know, they intended to bring their family, and so I
Okay.
wasn't sure if that was okay or if that was an appropriate way to.
Yeah, so really the purpose of this was the application of the approach. So whichever one you chose to do
Yeah.
was just kind of taking a stab at like, what might this look like in practice?
Oh, okay.
So if you're doing it with a whole system, kudos. I'll definitely give you feedback on that.
Okay.
So I'll let you know. I mean, and again, I'm a professor of effort. So if I see that you know, took a chance, even if some things like I'd be like, you know, this isn't really realistic, like here's another thing to look at, I
Yeah.
appreciate the attempt. So it doesn't sound to me like you did anything like super rogue.
Okay, and I think the only other question, which was just the referrals part of the
Mhm.
paper, what did you want us to? Obviously, we had to make it applicable for